We're going to go on now with assessment findings. So assessment findings for the burns, that you're looking at the skin color. It'll be light pink to black in color. Obviously black is going to be if we've got eschar, the dead tissue. We're going to note some edema or blistering. There will be pain in all areas unless we have a full thickness burn. If you have patient has a full thickness burn, they're not going to experience the pain. All right, we're going to be watching for hypovolemic shock, so be sure you know signs and symptoms of hypovolemic shock, such as tachycardia, hypotension, oliguria or anuria. Their breathing may be compromised. And we're going to want to check and assess entrance and exit wounds if the patient has electrical burns. Okay, medical management. The outcome of a burn depends on the initial first aid provided and subsequent treatment in the hospital. So your initial first aid, if you are to come upon this patient, is going to be to prevent further injury at the scene of the fire. So you're going to go back to your acronyms that you've learned a long time ago. RACE. So we're rescuing and preventing further injury. If the patient has already inhaled smoke, chemicals, steam, or flames, we're going to observe for respiratory difficulties, obviously. And then for acute medical management, we're going to maintain ventilation, fluid resuscitation, and pain control. All right, so impaired ventilation, we're going to be monitoring for swelling of the airways, inhalation of carbon monoxide. They may have acute respiratory failure, and any and all of these symptoms may manifest within the first 12 to 24 hours after the injury. We may notice some stridor, so if you'll remember, that's where the airways are really tight and constricted, so they sound like when they're trying to breathe. We may notice some tachypnea. We are going to need to use some warm humidified oxygen, and we may have to do the hyperbaric oxygen chamber. Okay, so the hyperbaric oxygen chamber, there's some information in your book on that as well. On page 1143. But in the hyperbaric oxygen chamber, victims of carbon monoxide poisoning are usually placed in here. And what it does is it administers 100% oxygen at 3 times greater than the atmospheric pressure. Therefore, it increases the binding of oxygen to the hemoglobin modules instead of the carbon monoxide to the hemoglobin molecules. Okay? Not every place has a hyperbaric oxygen chamber, but I do think UK does have one. All right, then we're going over to fluid resuscitation. So fluid resuscitation will be crystalloid and colloid solutions. The goal obviously is to restore the intravascular volume, prevention of tissues and cellular ischemia, maintaining vital organ function. So successful fluid resuscitation is going to be measured by urinary output of 0.3 to 0.5 milliliters per kilo per hour. It's measured very minute detail because it's a very exact measurement that we need to get, and it'll help us maintain vital organ function. Okay. Also, a low dose of dopamine can help ensure renal perfusion because dopamine is causes peripheral vascular resistance, which increases cardiac output, therefore increasing renal perfusion. However, this is a kind of question procedure nowadays, and so they're really not using it. All right, pain control. These patients are going to be in a lot of pain, so they're going to use IV analgesics. Morphine sulfate is the preferred pain medication. It provides the most comfort, sedation, and the duration of action is longest for these patients. However, if you are giving your patient morphine sulfate, you must have Narcan on hand in case of respiratory depression related to the morphine. Okay? All right, wound management. So Staph aureus, Pseudomonas, Candida, those are the most common microorganisms causing infection in the burn tissues. First thing you need to do is remove the client's clothing. You're going to shave the body hair around the burn. So why is it important to shave the body hair? Well, the body hair is a good source of bacteria into the wound, causing contamination. So that's why we're going to shave the hair. We need to cleanse the burned area and apply a topical antimicrobial. There's the open method and the closed method, which we're going to talk about in just a minute. And then you're going to close the skin with a skin graft or a skin substitute. All right, so open method is virtually abandoned since the advent of effective topical antimicrobials. However, it is still used on the face and perineum where it is difficult to apply dressings. The client is placed in isolation with sterile linen, sterile gloves, and gown is worn, and sterility, maintenance of sterility is vital to limit the exposure of bacteria and cause infection for these patients. All right, then you've got your closed method, which is actually the current preferred method. The area is covered with an absorbent dressing coated in an ointment-based antimicrobials, and then they will put a final dressing of a polyvinyl material over top of that, like a Telfa pad or something. An occlusive dressing is used to prevent bacteria from entering the wound, and they're going to change dressings every day. It is a very, very painful procedure for the patients. However, it has to be done daily to prevent infection, to prevent harboring of germs and bacteria there. Okay. Different types of antimicrobial therapy are going to be Silvadene cream, silver nitrate, Acticoat, Aquacel AG, betadine. They're not using betadine anymore. Gentamicin, Bactroban. Okay. There is a chart in your book as well listing antimicrobial therapy for you to look at on page 1146. All right, surgical management is probably going to consist of debridement, wound debridement, which is the removal of the necrotic tissue. All right, it can be accomplished in one of 4 ways. So it can be accomplished naturally, where the dead tissue just sloughs away from the uninjured tissues, or we may need to do a mechanical debridement, where the dead tissue adheres to dressings and is detached during the cleansing. So what I think of when I think of this mechanical debridement is like a wet to dry dressing change. So we're putting in the packing wet. It's going to dry in there. The exudate, the infected flesh or whatever is going to gather up on that material. And then we're going to pull it out, and we're pulling out all of the dead tissue. Then they have enzymatic debridement, which is an application of topical enzymes, or surgical debridement, where they use forceps scissors during dressing changes and wound cleansings, and it's very, very painful. All right, so after we do the debridement, we're moving on to the skin grafting. So the skin grafting is necessary for deep, partial thickness, and full thickness burns, because these are the skin layers responsible for regeneration that have obviously been destroyed. Having a graft will decrease the risk of infection. It minimizes fluid loss in the patient and quickens recovery time. It also aids in the mobility and function, because it will decrease the contracture development on the new skin. Okay, so sources of skin grafts. You have your autograft, which, as it says auto, it uses the client's own skin. So this is the only one that can actually be a permanent part of the client's skin that will never have to be replaced. Obviously, it has to come from the client themselves. The only exception to this is identical twins. So identical twins can graft for each other. So in the odd, rare case, hope it never happens, my twins should need something like that, they could provide skin grafts for each other. Then you've got your allograft homograft, which is human skin from a cadaver, and your heterograft xenograft, which is obtained from animals, and usually it's pigs. All right, now your allografts and heterografts are temporary and can be used only until the client's skin is able to be harvested. These grafts will only last about, it'll be about 7 days to 3 weeks before the body starts rejecting these grafts, and you'll have to use the autograft of the client's own skin at that time. Okay, so here's a picture of a graft taken from the patient's healthy skin. It goes through this little meat grinder thing and meshes it up, and then they apply it. And here's another picture for you, how they're going to apply the skin. All right, then different types of autografts. So remember, autografts are the only ones that can remain a permanent part of the client's skin. That we can do an autograft one of 3 ways. So we have the split thickness graft, a full thickness graft, and a slit graft. The split thickness graft uses the epidermis and a thin layer of the dermis excuse me, harvested from the client's own skin. And then the full thickness graft uses the epidermis, dermis, and some of the sub-Q tissue. Now this is only used when small areas of the skin are burned, and or if it involves the face, hands, and neck, because less there's less risk for contractures to develop with the full thickness graft. All right, then you have your slit graft, which is where the skin is removed from a donor site. It is slit, stretched, and used to cover a larger area on a different side of the body. Slit grafts are done quite often. However, there are some setbacks to having a slit graft done. One of which is that it increases pain for the patient because now they have two sites, the donor site and the site that was initially affected, that are causing a lot of pain. The donor site now has increased risk for infection. The donor site also has the potential for scarring with the skin changes, of being inconsistent. And then there's a delay in wound closure using the slit graft, as well as increasing costs and prolonged hospitalization with the slit graft. Okay, but it does have to be used at times. All right, they also have these things that are skin substitutes. They're bioengineered skin coverings that promote healing, such as BioBrand, Transite, and Integra. And these are described in your book a little bit more on page 1147 as well. But remember, these are forms of, these are not autografts, they are xenografts, really, and so they are only going to last for a certain amount of time before you have to move on to the patient's own autograft. All right, and here's an example of the Transite. Okay, then we've got cultured skin. Let's see, which is used especially when the wound is significantly large. They culture the client's own skin in a laboratory. So they grow the client's own cells in the laboratory. I don't know if you've seen those mice with the ears growing on their backs. It's amazing what they can do in medical science now. They can grow this in a petri dish, and they can grow skin from, if they take a postage stamp size piece of skin from you, and they can grow with this cell regeneration enough of the client's skin large enough to cover their entire body in 3 weeks. So that's a very short time. The disadvantage, however, is that pigmentation doesn't match exactly, but that's pretty minor, I think, compared to the great, the fact that you can use such a small piece of skin. All right, nursing management for these patients. Obviously, we're going to do wound assessments. We need to calculate fluid replacement therapy. We need to recognize and treat signs of shock. We need to give analgesics. I had a little typo there. That's supposed to be analgesics. We're going to cleanse the wound, apply antimicrobials, cover the wound with dressings, monitor for signs and symptoms of infection, and coping mechanisms for the client and family. Obviously, body image disturbance is a huge issue with clients with burns. And then we're going to need to encourage adequate nutrition. So again, we're going to need to increase their caloric intake, increase their protein intake in order to help with the skin healing. Now, once a graft heals, they will use pressure garments to smooth the grafted skin and decrease the scarring and skin contractures. The patient may have to wear these pressure garments for up to 2 years. All right, on page 1148 in your book, there is client teaching on pressure garments. Be sure you look over that. And then nutrition, it's actually on page 1149 in your book. So be sure you look over this little section too, nutrition notes. But burns are obviously a severe form of stress. We're going to have to increase our caloric intake to 4,000 to 5,000 calories per day. Wouldn't you just love to have that diet? We're going to increase our protein needs. Vitamins A, C, and zinc are also used. Now, TPN is used with caution related to the risk of infection. We're going to give TPN usually via IV. That's going to increase the risk for infection just right there in introducing something else into the body of the burned patient. But also TPN contains a lot of sugars in it. So these sugars are going to promote bacteria harboring there as well. So you have to be very cautious if you're going to use TPN in these patients. Okay, so I think that finishes up for burns, and we're going to move on to, I think I have disasters to do. So we'll move on to the disasters PowerPoint.